There is a little bit of data that 2 to 3 cups of coffee, probably okay. 4 to 5 maybe does begin to have a negative impact on fertility.
You got to stay up to do all the things.
Yeah, it's exhausting after a while.
This is On Nutrition, a podcast from Mayo Clinic where we dig into the latest nutrition trends and research to help you understand what's health and what's hype. I'm Tara Schmidt, a registered dietitian with Mayo Clinic in Rochester, Minnesota. This episode, fertility. In the U.S., about 9% of men and 11% of women deal with infertility. Having issues conceiving is a common and sensitive topic for many hopeful parents. It can bring up so many questions about strategy, environment, and diet. Do I need to avoid microplastics? How many supplements should I be taking? Do I need to lose weight? Here to answer some of those questions is Dr. Ainsworth, a reproductive endocrinologist at Mayo Clinic in Rochester, Minnesota. Dr. Ainsworth advises patients dealing with subfertility and infertility about their many options.
Good morning, Dr. Ainsworth. Thank you for being with me today.
Morning. I'm happy to be here. Thanks for the invitation.
Of course. There are a few wives' tales out there about certain foods that may help you get pregnant. Pomegranate, the core of a pineapple. Is there any merit to these?
I did an updated search of the literature before we talked.
Yeah.
I can't find anything. And I think, in reading articles, I don't know that any of us have found a published study that shows a higher likelihood of pregnancy. That being said, I don't think they're harmful, right, by any means, but it's probably not the magic answer if pregnancy isn't happening.
Yes. If it gives you some hope and some joy to eat pomegranate, I don't know if eating the core of a pineapple is very joyful. They're kind of woody. But yeah, you go for it. Fruit, we're all for it over here at On Nutrition. We've also heard about womb warming in traditional Chinese medicine. And it's essentially making sure that your uterus is warm by eating hot foods, wearing thick socks to ease blood circulation and possibly boost fertility. Any evidence in your review around that?
I didn't find, again, any studies, but also, I think Western medicine is one part of a much broader approach to health and to life, really. So again, do I think it's harmful? No. Can I guarantee or provide data that it is definitively helpful? Also, no.
Yeah. If anyone already assumes, likely, we are at Mayo Clinic and we do a lot of things, whether or not there's a lit review to be done or whether there's a meta-analysis. So this is not that we disagree with these things. This is not that they cannot be true as long as they are potentially safe. That would be, I'm assuming, the most important thing to talk to someone, your OB or your medical provider about. But not to say that it's not out there. And not to say that like getting cozy and having some soup and wearing thick socks sounds lovely, right? Especially in these cold
general
months.
Stress reduction, right?
Exactly.
If that's the answer, then it may very well be helpful.
Absolutely.
Is there any evidence that a diet that's higher in fat and protein would improve fertility for either parent?
Oh, not that I know of.
What about taking Mucinex? People usually take it to loosen mucus in their upper airway. So could it also thin your cervical mucus and make it easier for sperm to travel through?
I did find one study back from the 80s, which, in that era of fertility care, there was a post-coital check. Like people would come in for a physical exam and they would examine the cervical mucus and look for sperm. It's not part of our current practice. But in the 80s, there was a study and it did seem that people who took Mucinex had a difference in their cervical mucus. In that one study, which is a pretty small group of patients, there were plenty of people who got pregnant. So I still put it in the vein of things that might help, probably not harmful. Do I think we need to do it exhaustively, every day for months on end? No, but that was the one study from the 80s.
Interesting.
Have you heard any other stories or theories from your patients about certain foods or diets that have allegedly increased their fertility?
The one that comes to mind is actually after embryo transfer, which is, pretty far down the path of infertility. But I haven't seen a study on it, but there's a myth, at least, that eating McDonald's French fries improves the embryo transfer outcome. So I kind of laugh with my patients that was a good marketing campaign, right? It's not any French fry, but McDonald's. Does it hurt? No, but exactly. I don't think there's a difference in our embryo transfer outcome from that.
Yeah, maybe I was going to say we should do a study. We should not do a study, but it's interesting.
We probably could because lots of patients do this. just a survey
and
study.
I have a feeling that they have enough money to sponsor it over there at Mickey
Yeah.
So there's no magical food that will help you get pregnant, but that doesn't mean there aren't a ton of other factors that can complicate conception. So first, let's dig into the scientific definition of infertility. Is there a difference between infertility and kind of just having trouble or struggling to conceive?
Yeah, so infertility is really common. The World Health Organization came up with an update, I think it was last year, that 1 in 6 people trying for pregnancy will struggle to conceive. So really common, not that often talked about. The definition of infertility differs depending on age, female age, and to acknowledge that we often talk about male and female, which is, somewhat binary. So for people with ovaries, age under 35, if they have been trying for over a year and in that time have regular cycles, no risk factors for blocked fallopian tubes, they have a partner with sperm, a year without pregnancy under age 35 is infertility. Over age 35, 6 months. It's a shorter window because as we age, the likelihood of conception decreases. And over age 40, recommendations and offer at least to be seen for a fertility evaluation because that reproductive window really is much shorter than in our younger years.
So you want to get seen sooner if you're less likely to be able to conceive because of your age being a risk factor.
Right. And then there are other risk factors. So I mentioned a year of regular menstrual cycles, meaning regular ovulatory events. But if you don't have that, if you have polycystic ovary syndrome and you have 2 periods a year, it's going to be really hard to get pregnant, right? So you don't need to wait a year. You could be seen sooner.
Is there any counseling that you give on what to eat and kind of the connection between what we eat and fertility?
Yeah, the way that I generally frame it to patients is, first of all, diet is hard to study. There's a lot of different diets marketed to all of us, right? And
Amen.
Different diets marketed to people trying for pregnancy. There is no specific fertility diet. In general, the studies land on the Mediterranean diet, fresh foods, fruits, vegetables, healthy fats, avoiding processed foods. But it's not different, right, than overall health and many other conditions that come to the same conclusions.
Yeah, and we talk about this when we talk about nutrition and pregnancy, because a lot of people won't necessarily know when they are becoming pregnant per se. So if we can set you up the best we can for when you do become pregnant, right? So let's get all of the macro and micronutrients in you. Let's start taking a prenatal, just in case, kind of cover those bases, as we say. So it's maybe not a direct link, but it's certainly going to set you up for ideally healthy pregnant person and healthy baby.
Mm-hmm. And as it ties into weight, right, especially PCOS if it's common, but people who have irregular cycles and are overweight, losing even 10% of their body weight can bring regular cycles back, which makes trying for pregnancy easier, makes pregnancy safer, right? So there's a link in that way, but not so specific to exact diets or prescriptive diets, if you will.
Yeah, exactly. And we hear a little bit about people wanting to to detox. And I say that with that voice because I hear it more often than I would like to, because I believe that your kidneys and your liver do a great job of detoxing by themselves. If people want to improve their, let's say, organ functioning, we'll call it, with better eating patterns and let's say a plant-based diet, I'm all for that. But is there any link to doing that and an impact on fertility?
I think it kind of depends, right, on how that plant-based diet is done.
Yeah.
If we are maintaining like adequate caloric intake, if there's protein, and as you said, all of the components of the diet are there, I don't have a problem with it. I, again, don't think it's a magic fix to any of this.
I agree. So there's not really a difference between what you should be doing if you're trying to conceive and kind of everyone else in the world. But you might be more motivated, which works for me.
Right. And sometimes I feel like my job in that first visit in my area in infertility is to like release people from the restrictions that they have put on themselves, right? Because it is clearly not complete avoidance of chocolate cake that is the thing that's going to fix this, right? So I often tell my patients, within reason, permission to live your life a little bit, right? Like if that extra cup of coffee makes you happy, especially if it's before ovulation, you can do that and life will go on and the outcome will probably not be different. Which is freeing and frustrating because people would do anything, right, for this to work.
Yes, absolutely. How much does stress play a role? Like when you give people this little wiggle room or this glimmer of, hey, like you don't have to be doing anything crazy. Is there a link between stress levels and fertility at all?
Yes and no. So we know without any doubt that infertility causes stress.
Yes.
That part is obvious to patients and to me.
Yes.
When I think about stress causing infertility, extremes of stress that, impact the way the brain talks to the ovaries such that menstrual cycles space out or become absent, that seems like a pretty clear connection. But the general day-to-day stress that we all have, which is a lot, and infertility adds to it, that's not it, right? So the neighbor or the family member who says, like, just relax and it will happen. No, that doesn't work.
You kind of just want to punch that person, even though they have good intentions. Thank you.
Right. Yeah.
One in 6 people struggle to conceive, but a lot of factors like age or having irregular menstrual cycles are outside of your control. And while you can control your actions and diet, there's not much evidence that pomegranate, Mucinex, womb warming, and other strategies will work. Though it doesn't hurt to try them with your doctor's blessing. And there's no optimal diet to get pregnant. The only real guidance is to aim for a Mediterranean diet, fresh fruits and veggies, healthy fats, and limit ultra-processed foods. Essentially, focusing on nourishing your body adequately, so if you do become pregnant, you're set up for a healthy delivery. But don't stress yourself out trying to eat a perfect fat-free, plant-based diet. Enjoy those French fries every once in a while. You never know what could end up helping. Now let's talk about what foods to limit, supplements, and subfertility, the difficulty to conceive.
So I'm hearing that there are no specific food groups, certainly, that people need to avoid, right? So we don't want them going on extreme diets, protein, high protein, low protein, high carb, low carb, etc. So nothing that you're having people avoid necessarily is what I'm hearing.
Right. And often, my patients and I kind of talk that maybe a middle ground is if you have regular cycles in those first 2 weeks of the month before you ovulate, you are by definition not pregnant, right? So if you're going to a wedding and want to have a glass of wine, or you had to pull an all-nighter for your exam, such is life, right? And maybe after ovulation, when you could be pregnant, is the time not to make yourself crazy, but to be a little bit more thoughtful. Maybe that's when you avoid alcohol for 2 weeks. But I think there's nuance to all of this, depending on length of fertility and what the treatment is and the history too.
Do we have to worry about caffeine prior to pregnancy?
Yeah, there is a little bit of data that 2 to 3 cups of coffee, probably okay. 4 to 5 maybe does begin to have a negative impact on fertility during pregnancy, right? The recommendation 200 milligrams a day. But it's a little more generous in the preconception period, I think.
Okay. You got to stay up to do all the things.
Yeah, it's exhausting after a while, right?
Exactly. Excellent. Do you see nutritional deficiencies in your patients that you need to address or to treat prior to conception?
Different fertility practices have different perspectives on this. So there are some groups who check vitamin D levels. Low vitamin D has been associated with subfertility, if you will. Our group has decided, we live in Minnesota and nobody gets outside. Let's just supplement everybody. 2,000 international units today over the counter. But to be honest, I'm not checking more than that, which is, again, acknowledging like the Western medicine from maybe more holistic practices.
Okay. So you're going to have your patients take vitamin D just because of the latitude that we live at. Okay. Are you also having them take a prenatal during this time?
Yes. And this is more specific to pregnancy, preventing birth defects. So neural tube defects in the way the spinal cord forms associated with deficiencies in folic acid. So the most important ingredient in a prenatal vitamin is folic acid. And 400 micrograms, by definition, a prenatal vitamin has that. So I tell my patients, those really expensive ones, the ones that taste horrible that you saw on Instagram aren't better, right? So if you hate them and they were twice as expensive, don't use them. So there's really no right or wrong when it comes to a prenatal vitamin because they all have folic acid in them.
Okay. And what about folate? Let's talk about folate versus folic acid.
Yeah, so folate, precursor to folic acid, folate found in diet, folic acid in supplements.
Okay.
Both of them are okay and helpful.
There we go. Take your prenatals, everyone. And not the expensive kind if you don't want to.
Unless you like them, but a lot of them really taste horrible.
You just got to get them down.
Yeah.
Is there research about environmental toxins and subfertility?
Yeah, it seems to be a real growing focus in this in terms of microplastics and EPAs,
exactly.
right? So you can find a lot of studies about this. And I frame it to patients of there are probably simple things we can do. For example, not heating foods in plastics.
Okay.
You probably don't need to throw out your whole, dish
Drawer of
supply, your
Tupperware.
whole pantry, right? We don't have to be so extreme. And the data is still evolving, but I think it is one of the more simple things that people can do to feel like they're putting their best foot forward.
Okay, so maybe we can store in plastic, like store in Tupperware in the fridge. But if we're going to heat something up, let's heat it in glass.
Yeah.
Okay. Any thoughts on cleaning products, like ingredients that we should be looking at or chemicals that we need to avoid?
I know there's a whole field that's interested in that area of study. I don't personally tell people to avoid things once you're pregnant, not cleaning the litter box, right? That's different though.
Best excuse ever.
Yeah. Than what is in cleaning products. So, I think it's not specific to fertility. I think it's, health in general and where people want to put their time and energy.
But if you don't want to clean and you want to blame it on us, you can just say
sure. Yeah.
Heard that I'm not supposed to clean the kitchen.
Yeah. I often tell my patients, you can do whatever you want, but if you need to tell your partner that I said you couldn't, feel free.
Exactly.
Whatever.
Also, if you're the one who's going through potentially subfertility, infertility, and eventually pregnancy, they can clean the kitchen. Okay. So just suck it up.
In our dream world. Yeah. That
exactly.
sounds nice.
Just like you don't need to necessarily add foods to your diet to increase fertility, you also don't necessarily have to cut certain items, like alcohol, outside of ovulation. But it might be a good idea to limit caffeine. Now, when it comes to supplements, there's plenty out there, like vitamin D, folic acid, progesterone, iron, CoQ10, B8, and B12. Just talk to your provider about what's best for you before you start. And when it comes to environmental factors like microplastics, you may want to reheat your food in glass, but there's no need to live in fear. Although, if you're falling behind on your chores, tell your partner or family we said it's okay. You're just avoiding toxins. Now let's get into how prospective parents can manage both their weight and the uncertainty of the future.
Let's talk a little bit more about weight. One of the most common reasons that patients get referred to dietitians is because they're going through sub or infertility and it's recommended that they have some weight loss. So what's the connection there?
So different categories of overweight, right?
Mm-hmm.
In general, the more overweight someone is, the harder it will be both to get pregnant, likely related to regularity of cycles, but even in IVF, where we don't depend on the menstrual cycle, decreased chance of pregnancy. And then safety during pregnancy, increased need for C-section, complications related there. So there is certainly a relationship and also a relationship in both directions. So overweight is it's probably the most common, the thing that is talked about. And underweight has similar implications, both on regular cycles, safety of pregnancy, risk of preterm birth. So there is a relationship. A normal BMI class 1 obesity actually does pretty well when you look at the outcomes of fertility treatments, which I think is also maybe added support here to say we don't have to be absolutely perfect, right? Like trying to be within the middle of the bell curve.
Well, and I always remind patients, okay, if I'm helping you not necessarily to lose weight, that might be the outcome, but I would rather have a counseling session with you about improving your diet, which will help you lifelong, which will help maybe the partner that you're living with, which will help baby. So I'm not really having a weight loss consult with these patients. I'm having a healthy eating consult with these patients. And the end result of more fruits and vegetables, portion control, less ultra-processed food, less empty calories is likely going to have a weight impact. But I'm not here to say hey, your goal weight's this. We're just talking about healthy eating, which I hope carries into pregnancy, which I hope carries into that kiddo is eating, right? So I don't necessarily focus on the scale or the number of calories. We more so not hide it, but we frame it of let's eat healthier because that's going to be great all the time, pregnant or not.
Yeah, I think that's good from an overall approach to fertility.
Yes.
And many patients know this, right? clinics throughout the U.S. have different BMI cutoffs at which we offer fertility treatment, which is a whole nother kind of ethical and complicated issue. But for some patients, that framework gets thrown by the wayside because they need a BMI under 35 to be seen at the clinic that's close to them. So I just acknowledge kind of the added pressure that patients with infertility have around weight and specific numbers. Kind of unfair, ultimately, right?
Absolutely.
Because in an ideal world, focus, yes, on the health aspects and not a number is best for all of us.
Yes, we have an episode on weight inclusivity. And the hard thing is that if these people are doing anything, they'll do anything to lose the weight or to become a candidate for their treatment. And then we have to switch them to a framework of, hey, I actually need you eating really well balanced. So there's doing these like crazy fad diets and they'll cut out entire food groups. And then eventually, ideally, when they become pregnant, I'm like, please, can we bring some of those foods back in? But how stressful and how scary to be going back and forth between this restrictive mindset to now I'm growing human. Okay, but I don't want to gain too much weight because I was successful. It's a lot.
Yeah. On top of everything else we navigate in a day, right? It's a lot in terms of diet and exercise. I tell my patients, there is no perfect answer here, right? Whatever you're going to do that is sustainable and isn't going to be jarring and we come in and out of this, but let's really make this a part of our life is what I would suggest that they do.
Yeah. So how do you have that conversation? How do you bring up their weight or their diet? Do you simply say this is a risk factor and it may be impacting your ability to become pregnant?
Yeah. So I talk to every patient about it, regardless of their weight, because also, right, society is kind of in all of our heads. So first to normalize, like a broader range of normal than many of us feel. And then I do say that at either extremes, and I tailor it to who I'm talking to, right? And a negative association with both time to pregnancy, fertility treatment success, risks in pregnancy. And then there are times that I have to be pretty direct, right? We do also have a BMI cutoff. So to sometimes acknowledge, this is not what you want to do right now, but if you were amenable to this, pausing attempts at fertility to really focus on weight loss for a few months to not only make this possible for us to do this together, but more successful. That's really where our best time is spent. But it's hard. It's a hard conversation for me to have and certainly to hear.
Especially because they didn't come here on their first day of trying to conceive, right? This has already been a long road in the first place. To further pause is just that much more heartbreaking. But what we're doing is we're trying to help people be successful in the long run. So let's talk about some of the options in that pause. So GLP-1s are pretty hot right now. I've also had patients even go through bariatric surgery and be pretty immediately successful with pregnancy after, even though there's a time frame that we ask them to prevent pregnancy. So let's talk about that. So let's talk about GLP-1s first.
Yeah. So as you said, very common. We are not prescribing them in our clinic, but we are very often referring to primary care, to endocrine, to others to prescribe. The data about GLP-1s in pregnancy, to be honest, is just limited because it's a new medication. So current recommendations, don't try for pregnancy while on GLP-1s. Stop for 2 months before attempted pregnancy.
Okay. Bariatric surgery.
Another really good option, both short and long term. A much harder ask of people, avoidance of pregnancy for 1 year after that surgery to make sure weight stabilizes, any deficiencies are navigated.
Yeah, that first year in bariatric surgery, you are losing weight so rapidly. And depending on the type of surgery that you've had, you may have truly a malabsorptive procedure purposefully, which is the mechanism of action. So we need to kind of stabilize, like you said, weight and nutrient stores, make sure that they're eating well, make sure that they're maintaining a healthy weight to become pregnant. But yeah, it's a long ask.
What options are available to patients beyond focusing on their weight?
We would at least begin by diagnostic testing. Sperm counts, are the fallopian tubes open? Are they ovulating regularly, which often you can tell by history alone? And if they're not, what additional testing might we do to better understand the underlying cause? And then depending on what we find, our options are always continued timed intercourse, right? There's nothing that says you can't do that. We just have to acknowledge the lower likelihood of success. Or are we talking about oral medications, intrauterine insemination, IVF, donor egg, donor sperm, right? There's so many permutations of where we go, but it always just begins with a visit and initial testing to understand where in the process we might intervene.
There's so much stuff out there about fertility, not all based on scientific evidence. Where can listeners find reliable information?
Yeah, it is very overwhelming. One place specific to fertility is resolve.org. This is a national patient advocacy group that has just a wide breadth of information for patients with infertility, subfertility, needing fertility treatments for other reasons. And it is a very good place to dig deep if you feel like digging a hole in the internet. The American Society of Reproductive Medicine is our kind of national organization for fertility providers. They have a lot of patient-focused education. I think those are two places I would start.
What do we still have to learn about fertility and diet? What don't we know yet?
A lot of things. Yeah. The practice of infertility in the grand scheme of things is relatively new.
Mm-hmm.
And about a third of our patients have what's called unexplained infertility, meaning regular cycles, open fallopian tubes, if there's a male partner, normal sperm. That's a lot of people that we have no explanation for why this isn't working. So humans at baseline, I tell my patients, are not good at this, right? Chance of pregnancy per month, 20% under perfect conditions. But there's just a lot. And I'm sure that there are things from a diet perspective that may modulate some of these, even on a cellular level, when you think about implantation and the way the lining of the uterus, that environment communicates with the embryo, right? There's so much that we don't understand. So a lot is the honest and very broad answer.
More to come, we hope.
Yeah.
And of course, as we've mentioned, infertility is a sensitive topic, and sometimes factors are simply outside of the patient's control, like you said. Do you have advice for how patients can navigate this diagnosis and maybe even conversations, right? The second you get married, people are like, are you going to have a baby? Are you pregnant? The second you don't have a drink on a Wednesday at 10 a.m., people are like, are you pregnant? Stop asking people if they're pregnant, by the way. Anywho, that's a personal PSA.
Yeah.
But how do we navigate the diagnosis personally and then also having the conversation?
Yeah, I think it's really nuanced to the person, right? And to the people around them. So Resolve, I mentioned, has support groups. And again, they're a really trusted source of kind of support for patients. If you are a Mayo patient, we have a support group. I think people have benefited from that a lot. But I think it also goes, it's different per person, per couple, and throughout their time in treatment. So it still has a stigma, infertility, associated with it. And for that reason, is sensitive and hard to talk about. And it's really isolating in that way, that it's kind of like the secret, huge thing that's happening in your life that you don't talk about. So often I find that patients start like that, like, this is just between us. We're not going to talk about it. And for many people, as time passes and they're still in fertility treatments, they begin to share a bit. And I think there's a big role that community plays, whether it's someone going through infertility or not, just involving other people and kind of acknowledging the struggle and the hurt and sharing that load with others can be really helpful. But it's hard, right? Because as some of the comments that you'd mentioned, our patients hear all the time, and just acknowledging that holidays are hard. Mother's Day is really hard, right? When you've been doing IVF for 2 years. So
going to a baby shower is hard.
Yeah.
Right.
Or not going to a baby shower, right?
Yeah.
Which might be a decision that at some points in time you make to say, I love you and I love me and I can't be there today, right? Like both things could be true.
Yeah. Well, and the fact that you mentioned the frequency of infertility, or how many people are going through infertility, if you're willing to share and if you're willing to find someone to talk to, you'll likely find someone that's gone through it too, right? It doesn't have to be this big secret. If you're willing to seek support in maybe other people or groups, you're probably going to find someone who said, hey, I went through that too, or my sister went through that, my mom went through that. And it's nice to have someone to hold hands with.
Yeah. I do think people find that, and, to acknowledge the vulnerability and the real fear that comes with admitting it, because you don't know how someone will respond. But I think more often than not, it's a shared experience and a lot of support in being able to share it.
I agree. Dr. Ainsworth, you are such a blessing to your patients. This is a hard field to be in. You're talking to people every day about something that's really challenging. So I just think they're so lucky to have you on their team. Thank you for spending time with me today.
Yeah, thank you. I love what I do and happy to share a little bit of it with you today.
Having to worry about your weight on top of worrying about your fertility is an unfair burden. But unfortunately, weight does play a role in fertility. Being on the extremes of underweight and overweight can cause subfertility and complications during pregnancy. It's also important to know that some treatment centers may have a BMI threshold and may request that you focus on your weight through various pathways before trying to conceive again. Navigating infertility can be an isolating experience, but you are not alone. There are options like medications, IVF, donor eggs, and sperm. There are resources online like Resolve or the American Society of Reproductive Medicine. There are also many, many other people out there who know exactly how you feel. That's all for this episode, but if you have a follow-up question, leave us a voicemail at 507-538-6272, and we'll answer it in a future episode. On the next episode of On Nutrition, health technology.
So they pulled all of these ideas with zero scientific backing together and said 10,000 steps. And you know what? It stuck.
For more On Nutrition episodes and resources, check us out online at mayoclinic.org/onnutrition. And if you found the show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, eat well and be well.
This podcast is for informational purposes only and should not be relied upon as medical or legal advice. Always consult with a qualified healthcare provider for any medical questions. The appearance of any guest does not imply an endorsement of them, their employer, or any entity they represent. The views and opinions are those of the speakers and do not necessarily reflect the views of Mayo Clinic. Reference to any product, service, or entity does not constitute an endorsement of or recommendation by Mayo Clinic.